Hello, my name is Anna. I'm a Band 5 gynecology nurse studying medical ultrasound practice to be an early pregnancy sonographer. The title of this presentation is Ovarian Ectopic Pregnancy and the Role of Ultrasound in Diagnosis. In the first trimester, ectopic pregnancy is a leading cause of maternal deaths. This presentation will talk about the case of a 36-year-old pregnant woman who presented with a one-day history of lower abdominal and right iliac fossa pain. An initial ultrasound scan was highly suggestive of a ruptured right-sided tubal ectopic. She was managed surgically and recovered well. The surgery and histopathology observations concluded that she had a right-sided ovarian ectopic. This case is discussed in relation to the use of ultrasound compared to other modalities in the diagnosis and treatment of ovarian ectopic pregnancy. Ectopic pregnancy is where the developing blastocyst implants outside the endometrial cavity, the most common form being a tubal ectopic. However, as seen on the diagram, there are other sites that include abdominal, cervical, caesarean scar, interstitial, and ovarian. Sometimes they can never be seen and are known as a pregnancy of unknown location. This presentation will focus on the less common ovarian ectopic. Ovarian ectopic is a rare variant of an ectopic implantation that accounts for 3% of all ectopic pregnancies. Implantation can occur intrafollicular and extrafollicular. The case study I'm going to discuss today is patient A. She's a 36-year-old woman, gravida 2, para 1, one previous C-section, non-smoker, natural conception, no previous gynecological surgeries or infections, with stable observations. She presented to the Gynecology Emergency Assessment Service with a one-day history of central and right-sided lower abdominal pains. This became worse when passing urine or opening her bowels, causing shooting and pressure pain in her rectum. She also had right-sided shoulder tip pains and was complaining of dizziness and nausea. She had no vaginal bleeding. Her urine beta-HCG test was positive. Her last menstrual period made her 7 weeks and 2 days. On examination, she had mild lower and right-sided tenderness. Speculum examination showed a closed os, no bleeding, and mild cervical tenderness. The doctor then requested an ultrasound scan to assess for a query ectopic pregnancy. Signs and symptoms of an ovarian ectopic are likely to mimic those of a more typical tubal ectopic. Atypical presentation of ectopic pregnancy is common, therefore no symptoms should be ignored, no matter how insignificant it may seem. Typical signs and symptoms can be seen on screen. Through the thorough medical history and physical examination, we were able to quickly identify some of the common symptoms and likelihood of a ruptured ectopic pregnancy. This enabled a quick request for an ultrasound scan. Factors that may increase the risk of ectopic pregnancy include damage to fallopian tubes following surgery or infection, the use of an ICD, smoking, and IVF. However, most women who have ectopic pregnancies have no identifiable risk factors, and as we can see from the case study, neither did patient A. NICE Guidance 2019 found that the rate of ectopic pregnancy is 11 in 1,000, with the maternal death rate of 0.2 in 1,000. However, around 2/3 of these deaths are associated with substandard care. Ultrasound, in particular the use of transvaginal imaging, allows for early detection of intra- and extrauterine pregnancy. This can either offer early reassurance or allows earlier intervention when there is a problem, which then allows more patients to be treated non-surgically. However, ultrasound is not infallible and does not always give an answer. NICE Guidance found that the most accurate method was using a combination of ultrasound and serum beta-HCG testing when a diagnosis of intrauterine pregnancy cannot be made. The Royal College of Gynecology and NICE Guidance both advise the use of transvaginal ultrasound in the diagnosis of ectopic pregnancy. However, this also depends on the findings of the assessments. Due to the gestation and patient symptoms, it was determined that a transvaginal scan was the most appropriate to assess this pregnancy. The ultrasound scan was performed gaining consent from the patient and adhering to local infection control policy. The scan findings were as follows: anteverted uterus, endometrial thickness 10 mm at fundus. Endometrium appears regular in outline and texture. No evidence of intrauterine pregnancy seen. Right ovary not seen. Mass in right adnexa measuring 74 by 68 by 58 mm. Query contains fetal pole. CRL equals 9 mm, which equals 7 weeks and 0 days. No fetal heart seen. Query fallopian tube rupture. Large amount of free fluid in right adnexa measuring 41 by 17 by 59 mm. Left ovary not seen. Left adnexa contains large amount of free fluid measuring 66 by 63 by 22 mm. Free fluid in the pouch of Douglas measuring 66 by 63 by 22 mm. Findings highly suggestive of a ruptured right-sided ectopic pregnancy, suggest urgent senior medical review. When comparing the images to a normal intrauterine pregnancy, we can see the major differences that ultrasound can show. On this first picture, we can see a normal intrauterine pregnancy. In comparison to patient A, we can see the uterus, no contents, slightly thickened endometrium. We can also begin to see free fluid. Moving on to patient A's right adnexa, we can see a large mass containing a fetal pole with free fluid surrounding it, in comparison to an image of a normal ovary with no adnexal masses. As we have seen in the report, although the findings suggest a ruptured ectopic, a diagnosis of ovarian ectopic was not found until surgery and histopathology confirmation. When reviewing the Royal College of Gynecology guidelines, I found that there were no specific agreed criteria in the identification of an ovarian ectopic on ultrasound. Therefore, findings can be ambiguous and subject to the sonographer's skill and experience. Other factors that may affect the quality of the images are a high patient BMI and a limited field of view. Due to the rarity of an ovarian ectopic, there are very few studies outlining the features. A literature search found that the identification of ovarian ectopic can be difficult, but the main things to look for were identification of a mass or cyst with a wide echogenic outer ring, either on or within the ovary, applying pressure via the probe and being unable to separate the mass from the ovary. Colour flow Doppler may reveal a hypervascular rim, and contents of a yolk sac or fetal pole are very uncommon. The problem with these findings is that due to the ambiguity, corpus luteum cysts can be misinterpreted as an ectopic pregnancy or vice versa. Harrow 2018 found that the use of colour flow Doppler identifying the hypervascular ring are often found to be corpus luteum. This highlights that the use of ultrasound in identifying ovarian ectopic pregnancy is important, but should be used in conjunction with medical assessments, blood tests, and sometimes surgical intervention. As per protocol, the patient was cannulated and reviewed by a senior doctor. She was consented and immediately taken to theatre, where a laparoscopic right oophorectomy for ruptured ectopic and adiolysis was performed. The tissue was then sent for histology confirmation. Although not relevant in this case, ectopic pregnancy can be treated medically with methotrexate according to certain criteria. This again shows the importance of ultrasound scan, as this would allow for the fertility of a patient to be conserved and stops a patient from requiring surgery. There are many different types of imaging methods. Each one uses a specific type of technology and differs in how well they show what is happening in different body tissues. X-ray and CT uses ionizing radiation, which can increase the risk of cancer or childhood cancer if used when pregnant. They are also not ideal for imaging the uterus. Therefore, unless there is an urgent medical reason, they are not used in pregnancy. Ultrasound and MRI scans use non-ionizing radiation. MRI scans, although offering detailed images, are a more lengthy and costly process. Some require the injection of gadolinium-based contrast agents, which are discouraged in pregnancy as their safety has not yet been proven. Cowell et al. Argue that MRI can sometimes serve as a problem-solving tool when ultrasound has failed to accurately identify an intrauterine pregnancy due to a limited field of view or patient habitus. However, as this would delay treatment, it is not recommended in patients that are hemodynamically unstable. Ultrasound is the first-line imaging method for early pregnancy due to its accessibility, safety and cost. As discussed previously, when combined with serum beta-HCG testing, it is the most accurate way of diagnosing an ectopic pregnancy. Ectopic pregnancy is one of the leading causes of morbidity and mortality in the first trimester of pregnancy. Ultrasound plays a key role in the assessment and management of a suspected extrauterine pregnancy. In this case, a mass was detected, which allowed for a quick surgical intervention. With the advancement in technology, earlier detection of extrauterine pregnancies will allow for less surgical intervention, more medical intervention, and overall better patient outcomes.